Hello everyone, welcome back. So today we are going to talk about sleep studies, different type of sleep studies and why we do that and what's the benefit of that. So the sleep diagnostic in neuroscience. So welcome, today we will explore how neuroscience intersect with clinical sleep studies through three core diagnostic tools. So we are going to touch bases with polysomnography, multiple sleep latency test and wake up test. So the goal of today's presentation is to understand the sleep studies, understanding the polysomnography, MSLT, multiple sleep latency test, and the MWT, maintenance of wakefulness test. So why sleep studies? So sleep dysfunction can impair everything from memory to mood, and so we want to explore what are these dysfunction. So sleep regulates cognition, emotion, and neuroplasticity. The sleep disorders affect millions of people globally, and that affect their life and their interaction and the social interactions. Sleep monitoring is critical for diagnosis and also for diagnosis of these disorders and understanding the disorders and also research in sleep studies. So there are different sleep-related disorders. There are sleep-wake disorders. There are sleep breathing disorders, and there are dysomnias and there are parasomnias. So we talk about some of them, and we are going to talk about some others later. So this is just a brief overview about the sleep disorder statistics. Around 50 to 70 million adults in the United States alone suffer from sleep disorders. So in US alone, about 50 to 70 million people suffer from different type of sleep disorders. 60% of people don't seek help for their sleep problems. They don't even recognize, many people they don't even recognize they have sleep disorders and they just go on their life. 1 in 4 women and 1 in 5 men have insomnia in the United States. And also as many as 15 to 30% of males and 10 to 30% of females meet a broad definition of obstructive sleep apnea or OSA. So 80% adults use prescription sleep drugs, and restless leg syndrome also affect but 5 to 10% of adults and 2 to 4% of the children in United States. So what is the role of sleep studies? So the sleep studies can be used as diagnostic tool to identify underlying causes of sleep disorders, assess severity of sleep disturbances, monitor treatment effectiveness for these disorders. So the type of sleep studies we do mention is polysomnography or PSG. It's a comprehensive overnight sleep study, and also MSLT, multiple sleep latency test, which measures daytime sleepiness, and also maintenance of wakefulness test, which assess the awake during the day. So starting from the polysomnography um, uh, and other drugs or the test, what they are measured and what are they used for. So polysomnography PSG measures sleep architecture, and it is used for a diagnosis of sleep disorders. Various sleep disorders, we can use the polysomnography to identify that, and those in general polysomnography is known as sleep study. Multiple sleep latency test is used. It measures the sleep propensity, and it is used for hypersomnia or narcolepsy. If somebody has hypersomnia, they sleep a lot, or they have narcolepsy, uh, that's also so that this test is used to diagnose that. The next one, the wakefulness test, is used for wakefulness maintenance, and it is used for fitness for duty in daytime. So this is just an image of the very old, the first machine used for polysomnography. So Kenton, a researcher Kenton discovered brainwaves activity in animals in 1875. Then Hansberger defined alpha wave and beta waves in wakefulness and distinct from slower brain waves in the sleep. So he identifies these the delta and theta waves, which are slow waves. They were identified later in the 1950s, But Hansberger identified the alpha waves not first in 1920s, and then later he identified the beta waves. So the range of alpha waves is about 8 to 12 hertz frequency, 8 and 12 times per second, and beta waves are higher frequency, which 13 to 30 hertz. So when your eyes are open, you're awake, you have beta activity, and when you're awake but your eyes closed, you go to alpha activity. And when you go to sleep, so the early sleep, it creates a theta activity, which is slower brain waves from 4 to 8 hertz. And when you go to deep sleep, then you get to delta wave, which is about 0, 0.5 to 4 hertz. So in newborn babies and in the fetus, we don't see high frequency because the um, lack of myelination of the cortical neurons. So we see delta brushes, which is uh, random intermittent delta waves. It's not a continuous delta wave. And when they're born, we see delta waves, which is normal in a newborn. And then in 1 year old, then theta waves, so they get faster. And later in life, you get alpha and beta wave. So another researcher, Loomis, he worked on the first overnight EEG leading to the development of the sleep studies or polysomnography. So polysomnography is a powerful tool. It's also a non-invasive recording test that is used in conjunction with sleep study. Polysomnogram can reveal different type of sleep disorders, and these disorders can be the most common one is sleep apnea or obstructive sleep apnea, restless leg syndrome, and rapid eye movement behavior disorders. So the treatment to treat a polysomnogram test uh, so it is a test which is done at night in a very quiet and well lighted room. Well lighted means that the light is very dim. It's not dark. It's not bright. Very dim light, so a person can go to sleep. The temperature is maintained, so it's comfortable because sleep hygiene is very critical for good sleep. And sleep hygiene means the time of sleep, the wake for when we what time we sleep, what time we wake up, what type of clothes we wear, what type of temperature we have in the room, what type of bed is that, the disturbance, the sound, the light, all these that can help in going to sleep or disturb, can cause disturbance in sleep. So all these, when you go into the sleep study, you think you're going to a hotel room with a nice quiet temperature, and nobody's going to disturb you during the night. And so once the study is done, it's an all right 5-hour recording. It is interpreted by a neurologist or a sleep specialist later, and then the next day or after a few days, and then it's shared with you depending on what is the diagnosis of the disorder. So what are the clinical significance of polysomnography? The polysomnogram work by monitoring a patient's sleep stages and cycle. So when the study is done by having a person sleeping in bed, comfortable bed in the sleep study room, and with a different type of recording, EEG, MG, and all this one, we are monitoring the stages. Especially, if the person is going from stage 1, 2, 3 to REM sleep, and then wakes up, or then does it wake up? How many times it wakes up? Does the person snore? How many times it snore? Uh, uh, what is the duration of the REM sleep, what is the duration of all the stages of sleep. So all this done during the measurement is done during these studies. So the doctor, depending on the results, the doctor may recommend a polysomnogram if they suspect the following sleep disorders. If you go to a physician and you are complaining about daytime sleepiness, tiredness, even you could sleep all night, you go to bed, but you're tired all day, you cannot focus, and all these issues which are related to sleep disorders. Most common one, the physician will ask you to go for a sleep study or polysomnogram. If this person, doctor suspect you have a narcolepsy or sleep apnea or REM sleep behavior disorder or insomnia or sleep related breathing disorders. So all these, so you have to go to the polysomnogram and get study done. So this again, a polysomnogram is a comprehensive study of sleep stages, and it records many characters to diagnose different type of sleep related disorders and monitor in all these disorders. During these studies at night, there's 5 about approximately 5 hour study. Airflow and respiratory effort is measured with the carbon dioxide sensors. Also, nasal pressure transducer to measure the nasal pressure and snoring. Audio and video recording is also done. There's a camera, and then the video recording, which is time log. So here you can see the changes in EEG or EMG, and also what is the movement you are doing. You are kicking the leg, you're waking up, you're turning the back, how many times. So, and audio, there's also camera attached to your throat, so and to record any snoring during the sleep. So respiratory inductive plethysmography belt, which is the belt around the chest and belt around the abdomen. They also place so they measure the respiratory effort and abdominal movement during your sleep. Electrocardiogram, ECG or EKG is also monitored. A pulse oximeter also record the oxygen level. So ECG is monitoring cardiac activity, and pulse ox is monitoring oxygen level. Because if you have sleep apnea, you have obstructive sleep apnea, then you can see, okay, how much obstruction to the flow is, there's a decrease in oxygen. So diagnosis of sleep related breathing disorder can be monitored with sleep polysomnography. Obstructive sleep apnea can be detected with 90% reduction in airflow for 10 or more seconds if you have more than 10-second reduction of oxygen. Obstructive hypopneas require drop in airflow 30% for 10 seconds. So if there's a drop of oxygen airflow more than 30% for more than 10 seconds, this is called hypoapnea. It's more than 90%, this is called obstructive apnea. CPAP, which is treatment, BiPAP, positive air pressures, digestion can also be performed in study. So we can attach the CPAP and BiPAP and see what is the best level of pressure that can help in the patient. Polysomnography can be used for diagnosis of narcolepsy, followed by multiple sleep latency test. And REM sleep behavior disorders and periodic limb movement disorder also can be tested using the polysomnogram. So we are monitoring the limb movement in this study, and we can identify that. So different complications that can happen, which are not very common. Polysomnography is a very great tool. It's a non-invasive and very simple tool. Some drawbacks can happen. One of the limitations is due to a person in a new sleeping environment. You are not sleeping at home in the regular bed, may lead to skewed result. The result may be not correct, and sleep latency may increase, and sleep quality may be reduced, because if you are comfortable in sleeping on your own bed in your own room. So medication changes before polysomnography can also affect if there's a change in medication. It's also important the patient keep their skin clean, avoid lotion or gels that may lead to electrode interference, because we are placing the electrode on the body, on the face, muscles, and so you have to use, you're not putting the gels and lotions and cream when you, but at the same time you make sure you take a bath and you're clean and there's no dandruff or dry skin or dirty skin. But the cost of polysomnography can also be expensive, and insurance typically get the prior authorization from the insurance company, and that may affect your scheduling, but most of the insurance companies, they affect the sleep study. So this is just a schematic diagram where we have multiple different type of recording, a sensor belt on the chest and abdomen, electrooculogram, EOG, movement of the eye, ECG for the heart, and then EEG for the brain, then oral nasal flow sensor for the nasal flow, chin EMG, muscle on the chin to movement, and then pulse oximetry on the fingers, and then muscle electrode on the limb for the leg movement. And on the left side we can see we have EEG, which we can see beta activity awake. Then stage 1 you see alpha, theta, and stage 2 you get delta activity, theta activity. In stage 3 you get more delta activity, and REM sleep you get high frequency as well. And level of consciousness can also be monitored during this 90-minute cycle. So every cycle of sleep runs about 90 minutes, which has stage 1, 2, 3 and REM sleep, and then you may not get all three stages, but you get REM sleep bigger and bigger throughout the night. So what is the importance of these studies? So why sleep matters? So sleep is essential for physical and mental health of a person. If you don't sleep well, you will have severe complication. Severe significant. It affect your brain, affect your heart, if your body system, it affect your um, hormonal level, it affect your cardiac activity. There are a lot of different applications. Side effect if a person doesn't sleep as recommended. It affects your daily life, it affects your mood, it causes mood disorders, it also affects cognitive function, and there's a cognitive function decline when you sleep low. Um, so the sleep is also needed for underlying cause of the sleep, and it helps in tailoring the treatment plan which is used for the study. So let's go and talk about some little bit about sleep study. Number one, polysomnography, also known as regular sleep, just sleep study, is a test used to diagnose sleep disorder. As I mentioned earlier, PSG record your brain waves and oxygen level in the blood, your heart rate, your breathing, your muscle movement, your limb movement, your chest movement, your abdominal movement, your eye movement. So all these movements are recorded during at the same time in time locked manner. Sleep study may be done at a sleep disorder unit in a hospital or a private clinic. The test is performed usually at night, but may be done during the day for the shift worker and if you are not available to go for nights. So in addition to diagnosis, sleep study might help to determine the treatment plan if you have been diagnosed with a sleep disorder, and also might be used to adjust your treatment. Sometimes you may be able to do the sleep study at home. Some sleep apnea tests are used to help diagnose obstructive sleep apnea, or also known as OSA. So PSC monitor your sleep stages and cycles. It can how many cycles you have per night. It can identify when your sleep patterns are disrupted and why they are disrupted. What are different movements you are doing that? How are you waking up or you are asleep? Which stage of sleep you are? Typical process of falling asleep begins with a sleep stage called non-rapid movement, non-REM sleep, and then you have stage 1, 2, 3, and then you go to REM sleep. During this stage, brain waves slow down from beta to alpha to delta to theta, and this is recorded during sleep study and called electroencephalography or EEG. After an hour or two of non-rapid sleep, brain activity picks up again, and this sleep stage is called rapid eye movement, REM sleep. Your eyes quickly move back and forth. Most dreaming occurs during this stage of sleep in REM sleep. You typically go through the multiple sleep cycle, and typical non-REM and REM cycle combined last about 90 minutes, and you have 4 to 5 cycles every night supposed to have. So this is you can see in children we have start from awake, then REM 1, 2, 3, and this is an old size we used not stage 3 and 4, but now stage 3 and 4 are combined, so we don't use stage 3 as a stage, and so it's 1, 2, 3 and non-REM sleep. And you can see compared the children have longer REM time and then get shorter, and young adults this again they don't go through stage 1, 2, 3 and then REM, and then you go to stage 1, you can go directly to REM. And elderly people they have multiple different type of them. So this is a comparison of non-REM sleep versus non-REM sleep from newborn to 2 weeks to 6 months, 6 years, 12 years, today and 15 months. So you can see REM sleep is much in the newborn, and REM sleep, non-REM sleep, they are almost equal. And then with progression, the non-REM sleep gets smaller, and non-REM sleep duration gets longer and longer. So different recording parameters during these sleep studies are according to the American sleep guidelines published in 2007. We do EEG recording, we do electroacoulogram, movement of the eye, chin electromyography, muscle activity of the chin, and then leg EMG for the movement of the leg muscles, airflow parameters from the result, and effort parameters for breathing, blood disease on the chest, oxygen saturation, pulse oximetry, body positioning, movement, and electroencephalography, cardiography. So this is a patient sleeping during the sleep study, and we have multiple monitor attached to this patient, and we are monitoring brain activity by EEG. We are looking for EOG for eye movement. We are using EMG for muscle activity. We are also monitoring electrocardiography for heart rate. We are also monitoring the breathing pattern by respiratory flow, the chest movement, the abdominal movement, the oxygen saturation by the pulse oximetry, and this is done to identify the sleeping disorders, which could be sleep apnea, it could be insomnia, it could be restless leg syndrome, it could be narcolepsy. So all these. So these are different recording from chin, eye muscles, leg muscle, and on the scalp for attempts EEG and then EMG and EOG. So there's also cardiorespiratory polosynchronography, which is done for us. So we are looking for sleep signal EEG for at least two channel of EEG, two channel of EOG and EMG, and then we do respiration and cardiovascular system and the movement system. So the next test is called multiple sleep latency test. So daytime test is a daytime test which is used for measuring sleep onset latency, how long it takes to patient to go to sleep, and REM appearance of the REM. It measures the physiological health, sleepiness. There are 5 nap opportunities every 2 hours. So so the test is done for how long it takes for a person to go to sleep and actually the REM stage of the sleep. So it measures the daytime sleepiness, and patient takes 4 short naps during the day, and sleep latency is measured for each nap. How much as soon as patient go to sleep, how much time it takes from sleeping to appearance of the REM. It diagnoses for excessive daytime sleepiness and also for narcolepsy. So multiple sleep latency test objective, it measures time to fall asleep. It consists of 4 to 5 naps during the day, and with a 2 hour, each nap is 2 hours apart, and the average sleep latency is taken for measurement. It is used to quantify sleepiness and diagnose excessive daytime sleepiness, including narcolepsy type 1 and type 2, and also for idiopathic hypersomnia. So the EEG and EMG can also be performed to detect the sleep stages and also the corresponding activity in this one. So you can do EEG and EMG, both of them, and there's a questionnaire comprising a 7-point scale. Common symptom for narcolepsy can also be performed to refine the diagnosis further. So this is a diagram. It's a graph which comparing the latency versus different trials. So we are trying to recognize the sleep disorders by doing all these tests, and the common sleep disorders are sleep apnea, which is breathing is paused during the sleep, and the second one is insomnia, which is difficulty falling or staying asleep. A person is difficult falling asleep. Then we also have restless leg syndrome, or RLS, which is uncomfortable sensation in the leg leading to an urge to move. So suddenly a person can kick. Narcolepsy is excessive daytime sleepiness and sudden sleep attack. So sleep apnea, insomnia, restless syndrome, narcolepsy are some common sleep disorders which are used for, these tests are used for diagnosing these disorders. And all these sleep disorders, they cause fatigue, difficulty in concentration, they call mood disturbances, and increases of accident during your work. So the third test, maintenance of wakefulness test, maintenance of wakefulness, or MWT. It measures the ability to stay awake. We are trying to how long a person can stay awake. Patient asked to stay awake in a quiet, very dim room with dim light for multiple sessions, and then wakefulness is monitored using EEG. So we are using EEG, and EEG is a very good assessing tool for stage of the sleep. So this maintenance wakefulness test assesses the excessive daytime sleepiness and used for treatment effectiveness for these sleep disorders. So when we're trying to interpret these study, sleep specialist, the sleep specialist, neurologist, or who are looking for the look on the data, they identify sleep disorders. They determine severity of the sleep disturbances. This is mild, medium, moderate, severe. Um, Develop personalized treatment plan for each patient, and then also they recommend treatment. Treatment may include lifestyle modification, medication, cognitive CBT, cognitive behavioral therapy for insomnia, continuous positive air pressure or CPAP, or BiPAP for sleep apnea. So different precaution depending on patient. So lifestyle modification are most common or consistent sleep schedule, keeping the schedule very consistent and not changing, sleeping, going to at the same time, waking up the same time. Optimal sleep environment, good temperature, light, sound, bed, clothes, limit caffeine and alcohol, no caffeine, no alcohol, which can before going to bed or in the daytime, regular exercises and stress management techniques, different medication that can also be used if these modifications they don't help, sleeping aid and the stimulant for sleep stimulants, and also antidepressants. But antidepressants are the last line of drug because they have severe side effect and they should not be prescribed on a regular basis. CBTI for insomnia teaches cognitive behavioral therapy for insomnia, teaches unique techniques to improve sleep hygiene and cognitive habits. Also, CPAP therapy, which is continuous positive air pressure, or CPAP, it treats sleep apnea by delivering pressurized air to keep the air open. So there's there's a mask or a tube that is inserted, a mask on your nose or tube in your nostrils, and there's a continuously pressure, and you maintain the pressure by electronically. They can also come with humidifier, and they can keep the nose humid, don't get dry, and they keep the pressure high and treat the sleep. So, for the conclusion of these studies, the importance of sleep is essential for all overall health and well-being of person. A person should have a good night's sleep, and it will affect your all different systems. A role of sleep studies: the sleep studies are crucial for diagnosis and treatment of sleep disorders, and encouraging healthy sleep habits, prioritizing sleep, uh, create a restful sleep environment, practice, practice good sleep hygiene, and seek professional help if you need in these conditions. So let's talk about sleep apnea. Touching a little bit about the sleep apnea. So there are two major classification of sleep apnea: obstructive sleep apnea and central sleep apnea. The obstructive sleep apnea can be subdivided into pediatric and adult, and then central sleep apnea, primary and secondary. The secondary sleep apnea, central apnea have kinesiological breathing, high altitude periodic breathing, PAP treatment emergent, and medical disorders. And the other are sleep-related hypoventilation disorders, sleep-related hypoxemia disorders, and benign variants of sleep disorders. So the first one, OSA or obstructive sleep apnea, is defined as a disorder of breathing during sleep. So this disorder is apnea caused by obstruction of the breathing during the sleep, and that obstruction is characterized by a prolonged partial obstruction or intermittent complete upper way obstruction, and this disrupts normal ventilation along sleep and normal sleep patterns. So we can see EBOG, this is a time, uh, so nasal pressure, and you can see thermal sensor and inductors path and oxygen level. So the last one is SpO2, blood oxygen level, and it drops significantly. And then you can see normal pressure is suddenly it stops and then start again. So what are the symptoms of obstructive sleep apnea? A person will have snoring, observed apnea. You can see apnea patient suddenly stop breathing. They have snoring and the snoring stop. And that time, many people sleeping next to that person say, okay, that person is quiet, so it's very good. But that's a time it's dangerous because that means the person is not breathing. So there's complete or partial obstruction of the airway, and then the person gasps for air and then wakes up, and that has caused disruption of the sleep. So hyperactivity occurs in children as compared to adults. Daytime slowness. So adults are sleepy in daytime, but the children are more hyperactive when they don't go to sleep. There's irritability in adults, and the kids, they have temper tantrum, and also depression, failure to thrive. So the kids and the children, their growth has reduced. They have low growth curves, and it leads to obesity. In pediatric, and it can cause anuresis, which is urinary incontinence, and causes nightmare, and also diaphoresis, which is increased sweating, and in the adults it's called nocturia, not urgency for urination. Then difficulty waking in the morning when you have sleep apnea, multiple times you keep waking up, you are tired and you cannot wake up. Decreased ability to concentrate all day, you cannot concentrate on the work, and your performance is poor in the school and also in the work. So here on the right side we see normal breathing with the tongue not falling on the soft palate or uvula. In the middle picture, you see partial blockage by tongue falling back, and at the bottom picture is the complete obstruction of the airway. On the left side, we see the cycle which has, due to this blockage, there's increased breathing effort and result in decrease in carbon oxygen level, blood oxygen, increase in carbon dioxide, and the result arousal, hyperventilation, and person go to, and that result in decreased carbon dioxide, increase in oxygen, then person go to sleep, and then hyperventilation, and then again collapse, and then obstructive sleep apnea or hypoapnea happen again. So apnea, so we can see the classification of the apnea is the airway flow drops more than 90%. In adults, the drop lasts for more than 10 seconds. And in pediatrics, there are two breath duration. So the two breathing duration, if the airway flow is dropped more than 90% for two breath in pediatrics, or in adults for 10 seconds, that is classified as apnea. For hypoapnea, if the airway drops more than 30%, plus the oxygen saturation drops more than 3%, or arousal on EEG, EEG waking up. In adults it should log for more than 10 seconds, and pediatric again 2 breath duration. The other condition is called REPA, or respiratory effort related arousal. When any flow drops, apnea, or it can be apnea or hypopnea, plus increased effort on breathing and arousal on EEG, and more than 10 seconds for adults and 2 breath duration, that will be characterized by respiratory effort related arousal. So if there's a apnea or hypopnea and then increased effort of breathing and arousal in EEG, that will be RERA. These are different polysomnographic. You can see left oculogram, eye movement, right oculogram, then C3A2, O2, there's EEG, and then chin EMG, leg EMG, then number of pulse rate 60, 65, 60, 60, EKG, heart rate, and then snoring. You can see snoring, and total nasal flow, chest movement, abdominal, and oxygen level. It's 91, 89, and then drops during apnea. When you see snoring, this stops snoring, there's no snoring, and then it comes back when the patient wakes up. So for diagnostic of obstructive sleep apnea, a person can have sleep. We have apnea hypopnea index, or AHI, apnea plus hypopnea divided by TST. TST is the total sleep time. So adding the apnea and hypopnea, that can happen during the total sleep time, and that's the index we get. For if you have 5 to 15 hypopneas per hour, that's mild. If you have 16 to 30, that's moderate. More than 30 per hour, that's severe obstructive sleep apnea. In pediatrics, 1 to 5 per hour is mild, moderate, 6 to 10 per hour is moderate, and more than 10 per hour is severe. So if this is OSA should be treated and have bad complication and bad outcome if it is not treated. For simple one, sleep depression can result in ADHD, it can result in anxiety, depression, irritability, it can result in weight gain, failure to thrive. The cardiovascular complication results in systemic or pulmonary hypertension, which is dangerous, can result in heart attack. It can also result in cardiovascular cerebrovascular accident, which are stroke. It can result in metabolic syndrome, insulin resistance, hypercholesterolemia, because hormone level is not regulated well. It also results in higher cancer risk, and it also result in increased mortality. So these are the different studies which are done, and these are the different complications that can happen. So as we mentioned earlier, the treatment and management uh, of these disorders depending on underlying causes, which include lifestyle modification, cognitive behavioral therapy, medications, continuous positive pressures, or when surgery in some severe type of condition, surgical intervention can be used to treat the sleep disorders. For the lifestyle and behavioral changes, weight management and its role in reducing obstructive sleep apnea severity, because higher BMI is associated with severe obstructive sleep apnea, and even the collar size is also as a risk factor. So positional therapy for mild cases, different sleeping on side or multiple pillows, avoiding back sleeping, flat sleeping, avoidance of alcohol and sedative before bedtime, that can also help. So there are various treatment options for treating an underlying sleep apnea. Number one is oral appliances, and this like how the different oral appliances work, what are the indications and their effectiveness, and the fitting process and potential challenges, and also helping how to apply them and interpret them. So they are all oral appliances. They are designed to reposition the lower jaw, which is mandible, and sometimes the tongue to maintain the open airway during sleep. And most common type of the appliance used is called mandibular advancement device, MAD, MAD, which is mandibular advancement device. So it keeps the lower mandible or lower jaw pushing forward. So it pushes the lower jaw slightly forward, and it prevents the collapse of soft palate, sorry, soft tissues in the throat, tongue, and leads to the airway, which can cause the airway obstruction. So it helps by stabilizing the tongue and other soft tissues, and this device helps to reduce the snoring and apnea episode in this patient. So the type of different oral appliances, mandibular advancement device is most frequently used oral appliance for OSA. Custom-made mats fitted by dental professional are often more effective and comfortable than over-the-counter. So you go and buy over-the-counter, they may not fit. So the custom-made are more tailored toward the person. And then tongue TRDs, which are tongue retaining devices. They are less common than mats, uh, and they hold the tongue forward to prevent it falling back, which is one of the most common cause of OSA, and which can result in blocking. So these tongue retaining devices keep the tongue forward and used primarily when patient cannot tolerate a MAD, mandibular advancement device. So this is just a picture of the mandibular. So this is and then how it's placed in the mouth when the person is going to sleep. So these are the mandibular devices. Without this person is sleeping. So the airway on the left side, you can see the narrow. So the airway is restricted in the back of the throat. But when the MAD device is used, it keeps the tongue forward and it moves the jaw forward. So when the jaw moves forward, it helps in decreasing the pressure on the back of the throat. So the tongue retaining devices, TRs, helps in snoring and apnea for different type of apnea. And these are the picture. It may be not the best and maybe hard for people to sleep with that, but this will keep the tongue, it snaps on the tongue and it prevents the tongue falling back when you are sleeping. So this is the another picture. So placement of this on the tongue, and then it stay on the tongue throughout the night. So what are the indications? So mild to moderate OSA. Oral appliances are most effective for patients mild to moderate. It's alternative to PAP therapy, positive air pressure, for patients who cannot tolerate PAP, because positive air therapy is, many people, they are not comfortable with that, and they don't sleep well, and they cannot tolerate, and they have discomfort, they have claustrophobia because they have a mass on the mouth and there's a lot of noise, and so the oral appliances offer a non-invasive and a portable alternative. You don't need to connect to the electric output or anything, and these devices can help in primary snoring for these patients. So the studies show that oral appliances can be effective in reducing the severity of OSA. So again, it's mild, just for mild apnea, and improving the daytime symptoms, particularly cases of mild to moderate OSA. The benefit includes case of ease of use, portability, and improved adherence to some patients, which compared to PAP therapy, which are not comfortable with that. Many patients find oral plasma more comfortable and easy to use, and during the travel than taking the PAP machine and using the patch machine. So custom versus over-the-counter devices. The custom devices are made by dentist or a specialist, and they fit to the person's dental anatomy, and they offer the better fit and the more comfortable, and they have more effectiveness. The over-the-counter are much more cheaper. They're less expensive, and but they're not custom made, and they may not be comfortable, and they may not fit correctly, and they may not be they may be a temporary solution, but they may not give you the best outcome. So for fitting mounting, so there's initial fitting, then follow-up adjustment, and sleep follow-up. There are challenges. The jaw discomfort and soreness may occur. Bite changes and dental shift can also, dry mouth and saliva can also occur. Now, positive air therapy, PAP therapy, there are different type of PAP therapy. PAP therapy works by delivering pressurized air to a mask into the airway to keep it open during the sleep. This will prevent airway collapsing, and main cause of, which is the main cause of OSA or obstructive sleep apnea. So we have CPAP, we have BiPAP, and APAP. So what's the difference? So the CPAP is continuous positive airway pressure, and it's the most common used type of PAP device. It delivers the constant level of air pressure throughout the night, and often considered as the gold standard for OSA treatment due to its efficiency. It's not recommended for mild, but mostly for severe or moderate to severe. Then we have bilevel positive air pressure, BiCAP. It provides two levels of pressure, or higher pressure for inhalation and lower pressure for exhalation. So pressure for breathing in and breathing out, for high pressure for breathing in and low pressure for breathing out. See, this is a CPAP machine. You can see the person sleeping. So this, many people, they are not comfortable with this, and they are not compliant to that, so they don't work well. So the air is going, the machine is delivering the air at a fixed pressure, which is set by the sleep specialist. It may be given with uh, humidity or without humidity, because without humidity, the continuous pressure can cause a lot of dryness of the nose and the mouth, but with humidity, it makes more breathing. This is another device, picture of device. Different manufacturer, different devices, different fitting, and one person may be comfortable with one, but not the other one. Then this is BiPAP, which is two level of pressure, inhalation and exhalation, high pressure during breathing in and low pressure breathing out. And then this is BiPAP therapy. So again, there are two different pressure, and it blows higher pressure when the person is breathing in, and low pressure when breathing out. So what is the benefit of this? It reduces the daytime fatigue and sleepiness by improving sleep quality. It lowers risk associated with untreated sleep apnea, such as cardiovascular disease, hypertension, heart disease, and cognitive impairment. It also generally improves overall quality of life, mood, and cognitive function. So a lot of benefit of PEP therapy. So it helps in all the symptoms which can happen during these patients with apnea or lack of sleep, and daytime symptoms, and that can happen in relieving those symptoms. So this is a comparative by CPAP flow and BiPAP flow. So CPAP on the left side is a continuous pressure, and more affordable, and the BiPAP is more complex, but it gives you two different options of two different pressure. So we can set up one pressure on CPAP, and we can set up two pressure on CPAP, inhalational PAP and exhalational EPAP. So the common challenges in the PAP therapy is comfort. Many patients struggle with discomfort from the mask and air pressure, and both of them, because there's continuous air blowing in your nose or mouth, and then you have mask on where it may cause claustrophobia. That's the sound of the machine, and that can also cause discomfort to the patient or the partner. The fitting a mask, if the mask is not fit, it can leak air and it will not be good treatment and effective treatment. The person may not be able to tolerate the pressure if needed, so if you keep the pressure low, that's not effective, but keep it high. It's difficult to exhale against the pressure because person there's a continuous pressure, or in BiPAP there's some kind of pressure. so breathing out may be difficult in some patient. And also claustrophobia and anxiety due to mask and sleep can also happen in this patient. So in order to help this patient to adhere that mask option to improve comfort, variety mask, nasal pillow are available. Humidification can also prevent dryness, and then gradual pressure ramps to start with the low pressure and then go up after every few weeks, and then support and education. So these are different type of CPAP masks: nasal pillow, full mask, face and then nasal mask, and then CPAP mask. So you can see different type of mask person can sleep with that. So different characters, positive pressure. So the CPAP, APAP, BPAP, and ASV. So they keep different pressure level. So CPAP is continuous. With APAP, you can see our pressure builds up, and BiPAP is positive negative pressure, and then ASV is continuous, stabilize the breathing and maintain upper air. It continuously adjusted inspiratory and expiratory pressure with the variable on demand and backup rate. So this is a paper we published, which is going to talk again later, hypoglossal nerve implant. So when the patient in severe apnea, they are not comfortable with CPAP and they are not compliant with CPAP. Even the CPAP or BiPAP is the best option for them. They are not compliant and they don't like to that, or the claustrophobia, and they didn't use that. Or many people, they start using and within 6 months they stop using that. So for those patients, one of the treatment option, the new treatment option is called hypoglossal nerve implant, HNI. So we put an implant so that the incision is made under the mandible of two incision, and then looking for the anterior belly of digastric muscles, and an electrode is placed on the cranial nerve 12, hypoglossal nerve. There are two branches, medial and lateral. One is supplying the muscle which contraction causes the tongue to come out, protrude. The other two muscles, when they are stimulated, they retract. So you have to make sure you are putting the electrode on the correct muscle, because if you put on the wrong one, then it may cause further apnea. So we stimulate, we test while the surgeon is testing by intraoperative neurophysiological monitoring, or INM. We do trigger EMG and EMG, and we identify the muscle, and then the surgeon places um, these stimulators on the nerve, and the battery is implanted in the chest. So the chest battery, and there's a sensor in the chest, and the sensor lead is identify the chest movement, and then it causes the pressure stimulation of the tongue during the breathing in, and it relaxes during breathing out, and that's a very high success rate. It's about 67 to 70%, but a good outcome for these patients. So, and for the studies, again, all these studies which are done, polysomnography, multiple sleep latency test, or maintenance of wakefulness test, all these studies are done to identify the underlying cause and then identifying the treatment option for these patients. So, for sleep awake studies, polysomnography is measurement is done to see the architecture of sleep. Patients going to stage 1, 2, 3, REM sleep, then coming to stage 1, then go to REM, or stage 2 and REM, and how long is the REM, how long is the cycle, how many times patient wakes up. So all the sleep architecture is monitored by PSG. With multiple sleep latency test is done to sleep onset latency, how long it takes person to go to REM sleep. And the maintenance of wakefulness test is done for wakefulness duration, how long the person can stay awake. The polysomnography is done all over the night. It's a minimum of 5 hour sleep. Multiple sleep latency test is done in daytime naps. There are five naps, 2 hours apart. And maintenance of wakefulness test is daytime, again, vigilance, keeping the patient awake in daytime. The use of polysomnography is to diagnose obstructive sleep apnea and respiratory breathing disorders. Multiple sleep latency test is done to identify narcolepsy and hypersomnia, because person is going to narcolepsy, have sleep all day, or they sleep a lot, hypersomnia, and then we see how if the person, these patients will go to REM sleep very quickly, maybe within 5 minutes. And maintenance of wakefulness is done for function of the sleep and for the treatment of. Okay, thank you everyone. So that was the end of today. So again, we covered different type of the studies, and the focus of the today presentation was the sleep studies, and 3 sleep studies which we discussed was polysomnography, multiple sleep latency test, and maintenance of wakefulness test. And these studies are done at different times. So one is done at night and two is done at day. And the purpose of these studies is to identify the sleep disorders, and they are focused on different sleep disorders. Polysomnography is associated is especially um, for apnea, obstructive sleep apnea, and multiple sleep latency is for hypersomnia or narcolepsy, and maintenance of wakefulness is for the so the person is able to stay awake or not. So again, underlying the sleep disorders. So thank you, and there are different tests done: EMG, EEG, respiratory breathing, snoring, leg movement, all these tests. So every test is a very specific, and we can talk in detail about each test. But I was trying to give you a brief summary about all these tests. And is anyone interested in going more detail, let me know, and I'll have you. Thank you again, and have a good day.